for a webinar, and gonna hand this over to Mr. Clark.
All right, let me see what I have to do. I made the presenter. Please close confidential window. What does that mean? Okay, show my screen. There we go. That's what I'm looking for. I had to get all the spy software off of here first. Okay. What are you guys seeing? Are you guys seeing my screen now?
Yeah, you're still setting up.
Does this look like?
Oh, that's
There we go.
Seeing an intake form?
An intake form.
Yes.
Fantastic. Okay. So what's today? The 4th? January 4th. Happy New Year.
Happy New Year.
Everybody. This is a gentleman who came into our clinic around the end of November. It was actually one of Paul's patients, so I only have some limited information here for you, but I got enough that we can work with. This is his intake form. As you can see, he had some headaches, pretty severe. You see that bar over to the right there, near that 9-10 mark, but constantly in that 5 to 6 area. The headache, stiffness, soreness, aching, stabbing, all the stuff there all the time. Just gets worse and sometimes better, but never leaves. He says that football, maybe an old football injury, he's not sure as to where it actually came from.
Well, that
Pillows, lack of sleep make it worse, but that's just stress stuff. He's done hot, cold, massage, Advil, stretching. Been to the doctor, had PT, does neck exercises, all of that stuff. Down here in the activities of daily living, we look for anything that jumps out at us that may be causing his neck pain. He does desk and computer work, like a lot of people do. Household duties, yard, cooking, improvement projects, pool, kind of general stuff. He gardens and he fishes. Does some elliptical, looks like he's not a very regular exerciser. Sleeping position back and side. What are we looking for when in sleeping position? Anybody?
Stomach.
Stomach, yes. Especially if they have a neck problem. You want to check to see if they're a stomach sleeper. This is just stuff that where he believes he could end up. Obviously, he doesn't know what's causing it. This is how much effort he's willing to put in. This is how much stress he's under, typically. So that's his basic intake form. There's a lot more to it, but I wanted to show you the basics of what he came in with. Then what we did is we did our chart. So let's go ahead and take a look at the chart. So this is this guy's chart. Get this out of the way here. And
Oh, shucks.
Tracy, are you still on the line? You still there? You working on it?
Nope,
You must.
I'm with you.
Oh, okay. Are you seeing the chat? Because I'm not seeing the chat stuff. So
Yeah, I got the chat stuff.
I just want to make sure I wasn't. You got it?
Yeah, I got it.
Okay. All right. Good. Okay. So basic stuff. So here's his chart. Let's go ahead and answer the first question. Do we believe this guy has a structural leg length inequality? And when you are, go ahead and raise your hand when you know the answer to that question. I'll let Tracy call on you.
Oh, that's better.
Oh, hang on. All right, so we've got a couple of hands up. And let's go with Greg.
I'm looking for the hand. I'm trying to figure out the total.
Oh, yeah. There's, unfortunately, I don't get to raise my hand. So, Marion, can you tell her where the hand is?
It's usually in the upper right corner, and the strange thing about it is when you click on it and your hand is up, there's a down arrow indicating that if you click on it, your hand will come down. So A lot of times when you look at it, you think your hand is the opposite of what it is, but it really is raised when the down arrow is on.
Oh.
You may have to, there's also on the top right corner, like a little drop-down menu with a couple arrows. You may have to open that to see the hand.
Mm-hmm.
It'll be in the upper right corner.
Oh, yep, she found it. Good.
Okay.
Okay.
Thank you very much, Mary.
Mm-hmm.
We appreciate it. Okay. Greg, we were going to have you answer the question.
Okay, Tracy. It appears that this person does have a leg length inequality on his left side, or actually inequality between the two, but longer on the left.
Longer on the left. All right. And what were you looking at there, Greg, just to refresh us?
Looking at the greater trochanter measurement in standing, and then also verifying that in supine.
Okay, and just the greater trochanter, or are you looking at anything else?
From greater trochanter to the heel measure, and also looking at the ischial tuberosity measurement.
The tibial tuberosity
Oh,
measurement?
tibial, excuse me.
Yes. Yes, very good. So what Greg saw here was that this area here was shorter. So we like to name the short bone.
Okay.
So the short bone here is the short right femur, is what we saw. Now this, what it didn't say on the intake form is this guy's been dealing with this neck pain for many, many years. And what I'm going to show you here in a bit is why, so we'll get to that. So we found out, yes, he has a structural leg length inequality, so we want to deal with that right away. Let's go to the next question and look at fixations. First of all, did anyone not get the leg length inequality? Did anyone see something different? No? Okay. All right, then let's go to the next one. And when you know how many fixations there are, go ahead and raise your hand. We get some hands up, Tracy? Tracy, are you there? Have I lost
Hey,
you?
we're going to go with Rita. Can you hear me now?
Yes,
I
gotcha.
can hear you.
We're going to go with Rita.
Is my hand up or down?
It is up.
Okay, just checking.
Yep.
I believe there are 5 fixations.
There are 5 fixations. Do you want to name them for us, Rita?
Yes, external auditory hiatus, occiput,
Hiatus, both superior on the left. Very good.
and the occiput, superior on the
Yes, that's
left. Also at the humerus, superior on the left again,
Superior on the left. Good.
and at the clavicle.
Good.
And I guess that would be iliac crest,
And the ASIS.
ASIS.
Iliac crest is this line up here.
Okay.
This is the ASIS right there. So, 5 fixations. So that's a lot. What do fixations tell us, Rita?
That it's usually muscular.
It's usually muscular. This guy, when he lays down to go to sleep at night, doesn't feel any better than when he's standing up. All right, can you see that? That it basically has all the same distortions. So when he wakes up in the morning, he doesn't feel good. And if you remember looking back at his intake form, it says what makes it worse. It says bad pillows or lack of sleep. When you talk to him, he'll tell you that he wakes up hurting. And so this is an indication. All of these fixations are an indication of that. So that's one of the things you look for. So the next one is subtle proprioceptive mechanisms. When you know the answer to that, go ahead and raise your hand.
Wow, look at them go. They're flying up. This is awesome.
Flying.
Oh, wait, one went down. They're psyching me now. All right, let's go with Merle.
Well, nothing changed from one side to the other.
Excellent. Yes. So, no subtle proprioceptive mechanisms in this guy. So, what does that tell you, Merle?
Well, he definitely has a muscular issue. It just verified the fixation issue.
Correct. What's it tell you about the organs?
Haven't done that one yet, but I'll take a flying leap at it. That he's definitely going to be having some digestion issues as well. There's probably some lung in the heart.
Well, the answer really, the real answer here is we don't know. Subtle proprioceptive mechanisms are, the more subtle proprioceptive mechanisms you have, the more likely it is for there to be an organ issue. Because he has none doesn't mean there isn't. It's not a negative test like that. But it's a positive test. So when you do have them, you know there are organ issues. When you don't have them, it doesn't mean that there aren't. Does that make sense?
Yes.
Does everybody else get that? I know that can be a bit confusing.
I have a
Anybody
question
else?
on that.
Yes, go ahead, Greg.
Does that mean then that they may be masked because the muscles are holding him in the position
Correct.
he's in?
Yes, because remember when we start talking about how much electrical activity it takes to run a muscle as compared to an organ, the reason why the organs show up in the supine position is because the muscles are turning off. And if the muscles don't turn off, they will still mask the impact of the organs.
Yeah,
The input coming into the body. So because we have these fixations and everything's being held, we really don't know what the organs are doing yet. What we'll probably end up doing is doing some muscular work and retaking the supine measurements after we've loosened up the muscles and seeing what happens to tell you whether this guy has visceral problems or not.
So let's say that if he had visceral problems, what would be some of the things that you might find with this type of situation?
You'd find subtle proprioceptive mechanisms. You'd find switching going on. That's the first indicator. If, let's say, his measurements stayed the same, let's say we evened out these over here in the standing, but when he laid down, they all went to this position, then you want to start looking at right lung, potentially heart up in here. Because this was being pulled up, we're looking at descending colon. Anything over here on this left side. It actually could be, you kind of look in this compartment and then down in this compartment.
Okay, so the real answer to that is from standing to supine. If there was changes, then those would be probably more of some of those issues that would be looked at and addressed.
Yes, absolutely.
Yeah.
Okay.
Yeah, that's one. When you take the visceral seminar, that's one of the things we talk about is how to figure out which organs are involved in that thing. So I would definitely recommend doing that, Deborah.
Right. Two
You want to become a babysitter?
two things. One, can I ask Derek? Can you type up a question and send that to me? Please just send me a question. And Marion, did you have a question relating specifically to this?
No. Well, I don't know if it's getting ahead because it's on the visceral work. When Randy said that the ASIS was high on the left, would be a reason to look at the descending colon on that side. My brain goes, why?
Okay, because typically when a organ is tight or too neurologically active, it fires into the muscles that surround it.
Okay.
So which muscles surround the descending colon?
Well, we got the obliques,
Obliques, yep.
psoas, iliacus.
Psoas, yep. QL,
Yes.
all there. Okay, so if the left QL and obliques fired, what would happen?
Can you hear me?
Yes, I just heard whoever said that.
Yeah, yeah, Derek. Just type up a question and send it to me if you would, please.
Okay.
Thank you.
Okay, so back to Marion. Which muscles would fire? Or I said if the obliques and the QL on the left side fired, what would that do to the hip in the supine position?
Well, and the QL would raise it.
Yes.
Let me picturing the obliques a second. I guess especially the external would have the ability to also raise the ilium there.
Very good. So there's your answer.
Okay. Thank you.
Any other questions on that?
I don't see any hands up. So yeah,
Okay.
we're good.
Very good. Okay, then the last question to ask on this guy, demands. Is he meeting the demands of the writing reflex? So go ahead and raise your hand when you know that one.
Okay. Let's let Renee jump in on this one.
I'm going to say no. Based on the Levitt reactor, he's not meeting the demands because of the relationship between the ASIS and the temporal bone and the PSIS and the occipital.
And what about that relationship there, Renee?
They should be doing the opposite, and they're
Should
both
be doing
going
the
same
opposite.
way.
And they're both going the same way. Very good. So that tells us, what does that tell us, Renee, if they don't meet the demands of the writing reflex? Did I lose you? You there?
Renee?
Renee?
Me?
Yeah.
Yes, Renee.
Sorry.
Yes.
What did you say?
Sorry to wake you. What does it mean when they don't meet the demands of the writing reflex?
When they don't, that
Yes.
that they have a gait pattern issue. I don't know.
Stab in the dark. Not necessarily, no. So why do we ask that question, Renee? Why do we ask, do they meet the demands of the writing reflex?
Because that ultimately has to do with like their ability to like heal, right? If they're not meeting the demands, they're going to tighten back up.
Yes, very good. When someone does not meet the demands of the writing reflex, they are typically in more pain and more dysfunction than someone who does. This person is going to hurt more because of that lack of ability to compensate.
Yeah.
So that's one of the things we're looking for. It also helps determine how frequently we need to see this person. When someone does not meet the demands of the writing reflex, I will typically start them at a couple of times a week rather than starting them at once a week, which is my standard. When they don't meet the demands, they don't hold very well, and they need a little more frequent treatment. Everybody get that?
Yeah.
Okay. That's why we asked that question. That's why that question is on there.
Can I add a little bit to that?
Sure, go
that
right ahead.
Thought? Just to take an additional step on that, if someone is not meeting the demands of the writing reflex, and they have a structural leg length discrepancy, we need to address the leg length discrepancies first before we start seeing somebody twice a week, because they are not going to overcome that deficiency without having the leg length addressed. So in the case of this gentleman we have before us, that's going to be our first step.
Yes, absolutely. That's the first step with anyone with a leg length inequality is to address the leg length inequality first. That's something we want to stick with. Probably didn't emphasize that enough. That is the first step. The chances are when we put a lift under this gentleman, his cranium will not even out because his Lovett reactor is not working properly.
Mm-hmm.
If the Lovett reactor were working properly, it should help to even out his cranium when he stands on his lift. Chances are it won't. And if he has an even pelvis and a crooked cranium, is he meeting the demands of the righting reflex? Anybody?
No.
No. The answer is no. What if it were the other way around? What if he had an even cranium and a crooked pelvis?
Yes.
Yes.
The answer is yes. He is meeting the demand. But if I put a lift under this foot over here, and it evens out his pelvis, chances are, well, we don't know for sure because we didn't do this, but chances are his cranium would remain crooked.
Haha, that's funny.
Yeah.
What was that?
We're good.
Okay.
Okay.
Sorry.
So that is what's going on here. So this guy comes in with some pretty severe neck pain. Let's talk about that. So what are we going to do for this guy for his neck pain? Where would we start? Well, Kevin kind of gave away the first step, right?
Go, Kevin.
What is the first step?
Putting in the lift.
Yeah, well, confirming the leg length and getting him in the lift, absolutely. What else do you see on this guy that may tell you something else we need to do first? Kind of goes in the category of leg length inequality.
Okay, somebody had their hand up and put it down. Who was that?
Who's messing with Tracy?
All right. I think it was Rita was going to ask you questions.
I'm just going to try and answer the questions.
Oh, you're going to answer the questions. Okay.
So, okay.
Go ahead, Rita.
What you got, Rita?
I was thinking about the pelvis.
That is correct. I don't know what tunnel you're in at this point. But
What did she say?
Am I in a tunnel?
your audio is coming through very choppy at this point.
Yeah, you're pixelating a little.
Can't understand her.
I
She
understand.
lives in the woodlands.
I speak pixelated. So
That's pixelated.
So what she was talking about is the hemipelvis. So when you look at this gentleman's sitting measurements over here to the right, what we see is a pretty good tilt in the PSIS and the crest of the ilium. So while he's getting his lift for his shoe, he probably is going to need a lift for his ischium as well. Everybody see that?
Yes.
Yes. Okay. And we'll look at his x-ray here in a second. I'll show you what we found. But you'll see, even in a sitting position, he doesn't meet the demands, does he?
Randy, can I ask a question?
Sure.
How old did you say this gentleman was?
That's a good question. I don't have his chart in front of me.
Well, the reason I ask...
If I remember, I think 59 is what I remember.
Okay. Is the clients that I've seen recently that seem to have a hemipelvis are more elderly and have been exposed to polio, and some even have had polio. And I'm wondering if you guys see a trend in that, or...
Yes, we do. Kevin,
Can I take that one, Rick? You know what? I just saw a client today. Came in post-polio syndrome, right side pain, the right hip and femur elevated, right shoulder depressed, but a leg length discrepancy. Send her off for an x-ray, and we'll get that back in the next couple of days. I think Randy and Tracy might agree with me on this one, that pretty much everyone that I have seen in the office who has suffered from polio has a structural asymmetry. That seems to be pretty much a rule as far as polio is concerned. What do you guys think about that one?
It's
Yeah,
pretty close.
I would have to say that it's nearly 100%.
Nearly 100%. Yeah,
Wow.
nothing is 100%, but nearly 100%.
Yeah, I'm trying to think, because I've had probably 20 post-polio, and they've all had some sort of dramatic asymmetry.
Some sort of asymmetry going
whether
on.
it be an arm or
right.
a leg or foot.
Okay.
Right.
So,
Yep.
yeah.
Great. Well, thank you very much.
Yeah, absolutely. So, just to follow up, Kevin, you want to say a little bit about the background of the person that you saw today? Just
This is this woman in her. She's probably about 60. Has been through pretty much every medical kind of approach to treating the pain that she has. It's been chronic for a long time. She's actually a physician's wife, and has been through every kind of Western medicine you can think of. Acupuncture, massage weekly, just everything. Continued treatment that she has to receive constantly in order to get any kind of relief from her pain. And as she was on the table today, I was explaining to her about leg length discrepancy and telling her that, you can do all those things, chiropractic, massage, Pilates, yoga, whatever you want to do, and they're going to make you feel better. I was telling her, I can get you straight while you're on the table here, but when you stand back up, those patterns are going to have to refacilitate because the leg is short. And sure enough, I was testing her on the test lift after the treatment. I took it away to show her how much it was, and as we were talking, she started to say, oh my God, my back is seizing up again on the right side. So it was a kind of perfect illustration of that. We can treat it while you're on the table, but unless we treat the structural asymmetry, the pattern will refacilitate.
So it's just a good example of the fact that I still, to this day, have not found another profession that looks for this asymmetry like we look for it. And looking for it, you'll see how common it is. It's somewhat amazing to me that people still aren't finding this. Because she really had been everywhere, and being the wife of a physician, she's been through every medical thing possible to get it. I mean, she's been in constant pain for years, and no one. It's something that Kevin and I both knew from her intake form, without ever seeing that she had a structural leg length difference, and they just aren't picking it up.
Right.
So don't underestimate the power of finding these things. It really is quite powerful. So let's go through this. We checked this guy for leg length inequality. All right. So what I'll do for you here is show you what it looks like. Oh, this one. Okay. This one. Yes. Okay. So can everybody see this X-ray? Yes.
Yes.
Okay. So this is what the guy's X-ray looks like. Looks like he stood pretty well. The pubic symphysis is pretty well in the middle. You'll see that pretty good cartilage there still. Good cartilage in this hip. Not as good over here. Can everyone see that's a little thinner there than it is here?
Mm-hmm.
Starting to wear that hip a little bit. Structural difference turned out to be 11 millimeters. And if you look, crest of the ilium measurement is also 11 millimeters, but the ischial tuberosity, right at 0. Right? So what kind of hemipelvis does he have?
2.
Right.
Right.
Right, small hemipelvis. Right? So the right side is smaller over here. Sorry, I was pointing with the pen. The right side is smaller. And so when this person gets an ischial lift, they're going to need it to sit on it on their right side. Everybody get that?
Yes.
Because that's going to bring up this side, bring up this sacrum, straighten this out here. But you'll notice how good this really looks down here. And the reason is a lot of his correction actually takes place in his cervical spine.
Mm-hmm.
So let's look at his cervical spine.
Yeah. While we're right here,
yeah.
Renee has a question. Yeah.
Yes, Renee.
Yeah, when you're doing the to figure out the millimeter difference, you're
Yes.
taking the crest of the ilium, and on the bottom, what do you measure?
The very bottom surface of the issue. You'll see down here, it's just as low as you can possibly go, the lowest possible surface you have here.
Okay, what are those lines like higher?
These lines.
Those.
That is the leg length.
The femur head.
That's the femur head.
Okay, so that's what you. Okay.
This is for leg length here. This group and this line down here are for small hemipelvis.
Okay. Okay, got it.
All right. Any other questions on this picture before I move on? You can see his flexion wasn't bad. Not really in flare, out flared. Just has an 11 millimeter difference.
Randy,
Yes.
this may not be the right time to talk about this topic, but something that's been really interesting to me lately is when you see someone with a leg length difference, what are the likely wear patterns that you would see in the spine, on the long leg versus the short leg, that kind of thing? And again, this may not be the right time for this, but
Well, the answer, I'm going to give you a very generic answer. And the answer is, it depends on the person.
okay.
We see all sorts of different wear patterns. And it really, I don't know why one person wears differently than another. But you'll see two people with the exact same 11 millimeter difference. And one of them will make up for all of it in their sacrum and have lower back pain, and the other one will make up for it in C1 and have migraine headaches. And I don't know why that is. I don't know why they choose to compensate where they compensate. But where they compensate is where you start to see the wear patterns and where you start to have the issues.
Makes sense.
But as to why one does one way and one does the other way, I really can't tell you. I have not found anything.
Okay.
I don't know if Tracy or Kevin can help you out with that, but
I really think in those situations it has a lot to do with their gait and how they hold their mass. So a lot of people will compensate rotating their pelvis, and I think that people who rotate their pelvis tend to have more wear, or people who shear their weight a lot. I had a guy last week who has a 22 millimeter difference, but most of his weight, normally at that difference we would see most of the weight shifted towards the longer limb. But that's not the case with this gentleman. Most of the weight is on his shorter limb, and so the cartilage is wearing thinner on that side faster. He's only about 28 years old, so it's really quite surprising to see the cartilage wearing like that. But the cartilage is wearing faster on the shorter leg side because he's putting all of his mass on that side and just flexing his right knee. So when I started to put the lift to test, what happened is he shifted his weight even more to that side. So we couldn't put 22 millimeters in all at once. We had to go incrementally because he was shifting his weight over. But we digress. I think we're getting kind of caught up in the leg length.
sorry. Yeah, absolutely. But so that's the short answer.
Okay.
And
So
Renee wanted to weigh in one.
Renee?
Yeah, I have one more question.
Sure.
For if they don't have a hemipelvis, then obviously, because this X-ray is backside, right? It's posterior side.
Sure, because
Is
the
it
right.
shot from
Yeah,
Yeah,
you could flip it over and change it, but yes, that's
So
what we're
if-
looking at here.
If he doesn't have a hemipelvis, then you would just take the anterior X-ray, just like of the front.
This is
Or
no,
is
this
that
is
the
an
X-ray?
AP X-ray. This is an anterior to posterior standing,
Oh, okay. All right.
but it just was flipped over. The film was flipped over.
Oh, I got it.
That's why that
Okay.
R is backwards up there.
Yeah, so we're looking at the posterior side.
Right.
Got it.
So
Okay, so his symptom was neck. So let's look at his neck for a moment. When you see something here, let me know what you see. Anybody can just shout out what they see.
I see the C1 is right against the occiput with no space there.
Yeah.
Okay, so we're looking at right here. There's the occiput. Here's C1, and she's looking at the fact that there's very little space in that C1, that area there. Almost none, basically touching.
It also does-
Ooh, what was that, Rita?
Rita, excellent. Also, it doesn't look like it's much of a cervical curve.
Very good. Very good, especially
yeah,
in this
what she
region
said was
here.
he does not have much of a cervical curve.
Thanks for the translation. Thanks for the translation. Thanks. Especially here. We actually see the beginnings of a cervical curve here between C2 and C3. And then it kind of flips around and almost goes the other way. And then it starts to come back again.
It almost goes the other way.
Yes. So this is what's actually a reverse cervical curve right here. And look at the difference. When he has a normal, up in the first couple vertebrae, when there's a normal cervical curve, do you see this hole?
Mm-hmm.
That is the neural foramen, right? That's where the nerve comes out. Do you see how those holes get much smaller?
Yes.
And then they start to get bigger again as the curve starts to restore down here. But this area right here, that's a great spot to impinge a nerve. Right there, because that hole got so small. Does everybody see that?
Yes.
Yes.
Yeah.
Okay. So this is an issue, right? This reverse cervical curve is a big issue. He also has a bit of a lateral deviation here, but it's not terrible. Part of his correction that he's made for that 11 millimeter difference is actually up in here and not really helping this out at all.
Yeah, but in looking at that, this is the left oblique view, so this is the left
Yes.
neural foramen. Was the right available, and was it remarkable?
It
in a
was pretty
similar
much
fashion?
symmetrical.
It was-
Yes.
it was
right,
similar.
Right.
Okay.
Yes. Yes. So looking at this, what do you expect to happen in this area as well, other than the neural foramen getting smaller?
Osteophytes.
Osteophytes, possibly. What about these discs?
Collapsing.
What would you expect with the discs?
You're going to be driven posteriorly. Oops, sorry. I'm sorry.
Yes, Marion's right. Marion's right here. Whenever you get a reverse cervical curve like this, you expect the disc to be pushed posteriorly. So that, in combination of losing this, that's not real good on the cord, right? Because the cord runs kind of through here. So you get that. So let's take a look. There would be his MRI.
No surprises.
No surprises here. There's C1, 2, 3, 4, and here's where it starts to go backwards, right? There's that reverse cervical curve we talked about. Pressure's on the front of these discs, and then what happens? Pushes right into the spinal cord here. Everybody see? There's the spinal cord, which is nice and gray, coming down. That white stuff, what's the white stuff? Anybody?
CSF.
Very good. Who was in our radiology class?
I was.
Anybody?
Just a ratio.
Greg?
Yeah, Greg
was
was.
here, right?
Kimberly was.
Kimberly was.
Renee.
So what type of image are we looking at here, guys?
T.
Anybody?
T what?
T2.
T2. How do you know that, Greg?
In a T2 image, the watery material or liquids are lighter color?
Or the white lighter color. Very good. Excellent. Just a nice little review of that for those of you who were there. So, okay, so we have this area impinging right in here. That's an issue, right? What's the surgeon going to do for this?
He's going to fuse it.
Probably going to fuse it and probably trim this guy right here.
Yeah.
That's probably what they're going to end up doing. What are we going to do about it? What is this an indication to do?
Work in the anterior cervicals.
There he is. I knew Derek would jump in on that one. He better jump in on that one. I'm treating a patient right now that he's sitting down that we had to do that. So, yes, treat the anterior cervical, specifically which muscles?
Longus coli.
Yes. And his partner capitis.
Right.
Very good. Those are the major players. Those are the big players in a reverse cervical curve.
Yeah,
Longus
Randy,
coli, longus capitis.
if you would go back to the X-ray with the oblique, the lateral oblique view.
Absolutely. Oh, there you go.
Because one of the areas of concern with this and making this correction, and we'll have to see how things shape up, and I'm curious to know. It's unfortunate we don't have the film that maybe this is open at this segment and closing at one of these other two segments. That it looks similar, but maybe it's the other side. Because as you increase the curve here, that's going to tend to close this foramen a little bit more.
Which
are you with me at C4 or 5?
We can't see a pointer on the screen.
Right, we can't see a
I'm
pointer.
sorry. Yeah. So down at
Down
the
here.
closed segment, up one.
Yes.
Yeah. So if he has a scoliosis in his cervical spine, which you can kind of see a little bit of, but his jaw is kind of blocking the way as you go superior.
Right.
But if you close that, if you actually create an extension there, that's going to close that foramen just a little bit more, or at least we run the risk of that.
Right.
And so I would think we would want to, kind of monitor that. Obviously, it's going to shift with wearing a lift because that's where his compensation is in his cervical spine. But I would bet that even though it looks similar on the other side, that closing foramen is actually at another segment.
It probably is at a different level. I don't think we had. I think this is the only X-ray he brought us.
Okay.
But yeah, that's probably quite true. So you'd want to, absolutely monitor his situation as you treated this. But the idea is when you see a reverse cervical curve, that should be an indication to try to get the pressure off of that spine there with the longus coli, the deep anterior cervical muscles. So just to finish this off, just so you can see this last one, here you can kind of see where the disc is protruding. Here's a...
No, they're not very good.
Oh, hey, Ramona.
Ramona's here.
What's not very good?
I didn't know my mic was on.
You didn't like my MRIs? What?
No, I don't like wasabi peanut.
Empty Arms Hotel.
Well, it's nice to have Ramona with us. Okay, so here you can see the herniation kind of popping out here. You can see a little bit of it at this level coming through. That's kind of what it looks like. And anytime it gets close to that gray, you get troubles.
Yeah.
So this guy's definitely headed for a cervical fusion if we don't do something about this. That's where he's going. With the amount of pain he's in this type of MRI, that is where he's headed. But he's not going to get any better, obviously, right? They're going to fuse him, and then the next disc is going to go because they don't do anything about that lower body. So let's get back to his actual chart. So we've corrected his leg length and his small hemipelvis. What to do next?
Fixations.
Fixations, right? And where would you think we would start with these fixations?
I know.
What do you got, Renee?
Well, if I were doing it, I would definitely start with the right hip flexor because of the low shoulder on the right side. I would release those so that I could raise the shoulder up.
Maybe, yes, absolutely. But it wouldn't be wrong to start where his symptom is. Because you've already corrected the pelvis difference with the lift, right? So this, you're assuming this is corrected. So we're going to go up and see if maybe, because we know there's a lot of tension on the front of his neck. Let's see if that's what's holding all of this. Because the other thing is, you know, he's coming in to get his neck pain relieved, and if you don't touch his neck, he's not going to like that too much. So seeing what we've seen on those X-rays and on those MRIs, let's go ahead and do his neck. You can tell that the only reason I don't want to start down here, Renee, not the only reason, but one of the major reasons is if you look at his coronal plane and his pelvic flexion, they're all really good.
Okay.
And when these are the problem, it'll usually show up over here as well.
All right.
Can you see that? His coronal plane was perfect, and he only had 5 degrees of pelvic flexion. So if there was a big imbalance here, you usually would see it over here as well. Whether it be projection or a flexion or something like that would show up. Right, his pelvis actually looks really good when you look at it from the side. Everybody see that?
Yes.
Yes.
Okay. All right. So that's kind of the point of that one is to see that we probably just want to go and treat that longus coli, get that released, retake some measurements, retake the supine measurements, check for any kind of visceral issues. And that's what we've been doing with this guy, and we found out that he's feeling extremely better at this point. He actually ended up, he put high school football because that's where he was injured, but he actually ended up playing college football, and now his son plays college football, and he's trying to hook us up with the college football team at the University of Florida to do that sort of thing. So he's become very appreciative of what we're doing. He also actually has some connections at the local newspaper, so he's going to try to get an article written on this whole thing too.
Wow.
So just a good guy to get better, because he's been all over the place and seen all this stuff and really wants to get out of pain, and he is, and he wants to do something for us now. So that was this guy. What I want to show you next is, give me just a moment here, because I want to show you an example that will case history. Okay. Here's another guy who came in. Same sort. Here's our intake form. He has this radiating pain coming around his right side that he got in a car accident on 7/08. He just came in this month, so it'd been there for about a year and a half. It's right at that T9, T10 area. It follows the nerve pathway for T9, T10, right around the right side. He can't sleep on his right side. He's been diagnosed with a disc protrusion. So he's had epidurals, which reduces the pain, but it doesn't really get rid of it. He's had trigger point injections. He's had all sorts of stuff done. This is his chart, and let me see if I can flip that for you here. Here we go. So here's his chart. In an effort of saving time, I'm going to just show you what we found. His chart looks very similar, right? Everything going the same direction, just like the last guy's chart did. And it all stays fixed, except for in his head. His head actually corrects when he lays down. But his body stays fixed. You'll notice his difference happens to be in the tibia. Down here, everybody see that?
Yep.
Yeah. Okay. His difference happens to be in the tibia. One of the things, here, let me get back to this. I wanted to show you as well was the second page of his intake form, and why we have the second page of his intake form. Rheumatoid arthritis, he's had fusion surgeries. L4, L5, L3, L4, and C6, C7. All right, so this guy happens to have had some serious work done. He was a runner, one of the things I found out, and when you run with the leg length inequality, this is kind of what you end up with, because he's also in his 50s. He's really not that old. You'll see the list of medications he's on.
Wow.
Wow.
He takes all those?
He takes all of those.
Wow.
And not overweight, relatively healthy-looking guy, just in a lot of pain. And so, I mean, whenever you see oxycodone, and oxycodone was APAP, I'm not even sure what that means. Prednisone.
Oh, my.
He's on some serious painkiller, and he can't sleep, right? Which is why he's taking Ambien.
Ambien. Jeez.
He doesn't have any swelling with the prednisone?
No. They're trying to get rid of some pain with the prednisone.
I think the prednisone would be for the RA, don't you think?
And it probably is. It probably is for the RA, because that's one of the drugs used for RA. But he doesn't complain of his RA. He just says his RA doesn't cause him any pain. His pain is all coming. It's just that serious T9, T10 pain. And you'll see he's retired.
Wow.
He did prior to the accident. He did some swimming and stuff like that, but he can't do anything now.
Yeah, Randy, that
So,
oxycodone APAP is
yes.
has several brand names: Endoset, Magneset, Percocet, Roxaset, and Tylox. So it's
So it's just another painkiller.
it's oxycodone with
like an extended release. Or something like that.
other medications included.
Okay.
With it, so, but Percocet being probably the most commonly known name. So, okay.
There you go. So yeah, another painkiller. So here is his X-ray.
Whoa. Wow. Oh, my.
So you look, this guy has the exact same leg length inequality, right? He has a 11 millimeter leg length inequality, just like the last case did.
Yeah.
You can't read it down here. I think it's too dark. But there's a 3 millimeter difference down here at the ischium and a 13 millimeter difference up at the ilium. So what's that mean, Renee?
Hemipelvis.
Hemipelvis, how big?
Did you say 13?
Well, you see this up here? Can you see
Yeah.
that? 13 up there, and down here that's a 3.
13 and 3?
Yeah, 3 millimeter difference at the bottom, 13 millimeter difference at the top.
Okay.
So how big of a small hemipelvis does he have?
Oops.
It's okay to say you don't know. That's
I
fine.
wasn't here for that part.
It's okay. That's why I wanted to clarify. What you look for here is okay, so let's say he didn't have a small hemipelvis. what you would see is 13 millimeters of difference here and 13 millimeters of difference here, because the whole hip would be raised 13 millimeters. But what you're seeing is 3 here and 13 here, so you subtract the 3 from the 13 to get a 10 millimeter small hemipelvis. Anybody have a question on that?
Can you say that one more time?
Sure. You take this number here and subtract this number down here. Because if they don't have a small hemipelvis, they'll be the same number and it'll be 0.
Okay.
Does that make sense?
Yes.
So 13 minus 3 tells us he's got 10.
Another way I like to think about that, if I'm having trouble visualizing it, is if you look at the ischial tuberosities and you say, okay, there's 3 millimeters of difference there. If I raised up that left one 3 millimeters, how much would still be left at the top? And that would give you your 10.
Does that make sense?
Mm-hmm.
Yeah.
Okay. So he also has a 10 millimeter small hemipelvis. And which side is the smaller side?
The left side.
The left side. Very good. Left is. So you would think this guy would want a 11 millimeter lift for his shoe on the left and a 10 millimeter lift to sit on the left. Everybody get that?
Mm-hmm.
Okay. So why did I give him nothing?
Because of the fusion?
Yes.
Yeah.
Because of the fusion, absolutely. But it's not just an across the board because of the fusion. Because of the way he's particularly fused. See the angle of the spine going off here?
Yeah, I was going to say it's a scoliotic pattern.
Yes. They fused him. Look where the spine's going down here when it enters the fusion. And look where it's going when it exits the fusion. All right? So it's tilting over here to the left, as it should with this small hemipelvis and this leg length. If I went and corrected this here and here, it would straighten up his lumbar spine. And in straightening up his lumbar spine, what would it do to this?
Increase it.
It would increase it. It would send it way over here.
Yeah.
Now, his pain is, what you don't see on this x-ray is above it, he corrects. All right, so it starts going off to the right, and then his body corrects and curves back to the left. And right where that curve is where he's herniating the disc. And I would actually make that herniation worse by correcting him. So just because they have a leg length inequality, if they've had a fusion, get a copy of their x-rays, because I would have gotten this guy worse by correcting him. Now, had I caught him before all of this, we could have probably prevented all of this from happening.
That looks like an abortion there anyway.
Yeah.
Well, what you see here is there are 2 separate surgeries. This was done at 2 separate times. This fusion here, see these screws? These 2 and these 2 were an L4, L5 fusion, and it's called a P-lift, which means they came in from the back. They came in posteriorly and put these screws in. Then later on, right, as it always happens, the one above it went. And then they did what's called an X-lift, XLIF, which means extreme lateral intervertebral fusion. And so they came in from the side and put these screws in from the side between L3 and L4. So you see how these screws are different than these screws? So he actually had 2 separate surgeries.
Wow.
This is all a result of this leg length and this hemipelvis and him being a runner. But because of this, we can't correct it now. All I can do is try to loosen him up and keep him loose. I'm actually got a call into his surgeon because he may have to go in for another surgery. And if he does, I'm going to see if they can correct this.
Wow.
I'm going to see if they can actually, because they can straighten it. They can see how much longer the rod is here
Yeah.
than the rod is here. We need this rod to be longer to even that up to try to straighten this up. And if the surgeon is able to do that, if this isn't so fused that he can't do that, then we can go down and correct this and try to prevent the next one from happening. But what you don't see here is he already had that fusion in his cervical area as well. So this is one of these we caught him too late.
Wouldn't the surgeon be able to see that?
They typically just fuse them where they are, Eric. That's the normal way that fusions are done, especially because fusions are becoming less invasive. They're basically doing a lot of this through very small holes.
Oh.
So they just take the screw and put the screws right wherever the vertebrae are. They don't open up the whole back and they don't even see the whole back. They only see the little piece they're screwing into. So,
Randy, I have a question.
Yes.
Just studying this X-ray, looking down at the pubic symphysis. It looks like there's a closing on the superior end of that.
Right there. Yep.
Exactly.
Very common with this leg length stuff, that you start to see the superior aspect thinner than the inferior aspect. And sometimes you'll even see an upslip here, where it starts to slip up on the pubic symphysis.
Okay.
But yeah, there's still some cartilage there, so he's not in pain, but if that gets bone on bone, it will become painful. And then they can go and fuse that too.
Yeah.
So
Yeah, and
this guy is mid-50s at oldest.
Wow.
yeah, he's pretty young.
Wow.
So he's got to deal with this for a long time now. So that's why on an older person, I wouldn't even discuss doing the surgery. But this guy is pretty healthy other than this stuff. He probably has 30 years or so left. If we can correct this and give him 30 better years, it's worth going in and doing surgery for.
Yeah.
So that's why the call is into the surgeon. I'm actually going to talk to, since you can't get a hold of the surgeon, the nurse practitioner is where I'm actually going to end up talking to first. But I'm going to show her this X-ray and say, this is what we think is going on. Can you talk to the doctor about possibly straightening this guy up? So this is just one of the, we show you a lot of, put the lift in, put the lift in, put the lift in. Every once in a while you run into a case that is not what you want to do. And this is the kind of case that will show up like that. So I wanted you to get an example of that, so we could see when you don't do it. What other examples would there be why you don't put the lift in?
Because someone's older and they fuse naturally themselves for arthritis?
Yeah, absolutely. That's another great reason. Let's say they're 85 and they have these natural fusions that have happened and they look just like this, just without the screws. I'm not going to put a lift under that person. So there are some reasons for that. So any questions on this?
No, that's good stuff.
No? All right.
Hey, Randy.
So, yes. What was that, Greg?
Just along that line, it'd be really interesting to me, maybe in another meeting, to talk about the amount of lift that you give an individual based on the criteria you're looking at. Things like this, you wouldn't give them any lift. If they're a certain age and they have other factors, you might give them this much lift versus a full lift.
I'll give you the short answer if you want it.
Okay.
The short answer is you take the measurements, you put them in the lift, and you measure the cranium. wherever their cranium starts to go off is too much. That's the short answer.
Okay.
So you don't want to make their cranium worse. As soon as their cranium starts to get worse with the lift, you back off a couple millimeters. That's the general rule.
Okay. Great.
And generally, people over 50 don't take more than about 10 millimeters at a time.
What was the age? 50?
About 50.
50.
That you really don't want to do more than 10. If you find someone, let's say, at 22, like Tracy had found, you don't want to do more than about 10 at a time.
Yeah. Yeah, and that guy, I remember, was 28. So
Yeah, he was only 28.
But he was a competitive cyclist, and as a youngster growing up, so he had, used up his resources as a racer, and had,
Kind of
and
amazing
then,
he was able to race with 2 centimeters difference in his height.
and then as an American racer, though, you only have to really be good at left turns in criteriums, and his left leg was the shorter leg, so it actually was an advantage for him because it lent itself to making left turns really well. So.
Nice.
which is kind of entertaining, actually.
It is, yes.
Cracking up at that.
So,
cool.
Kevin, Tracy, anything you want to add?
And looking at this guy, there really is an opportunity for him if he's willing to, pay the price and go to the right physician. Because I had a gentleman like this back around 2000 who had a couple of back surgeries, and his workers' comp insurance package was denying him the opportunity to get a corrective surgery. For some reason, they just kept knocking him out of the loop for getting surgery. He finally settled his workers' comp case, went to a surgery, and found a surgeon. And this is kind of the mark of a competent and compassionate surgeon. He actually canceled 2 other surgeries because when he got in to doing the surgery, found misalignments like this case, and needed to take extra time to make sure the vertebra got lined up before doing the fusion, and took cages out, redid the fusion, and the guy was in surgery. It was supposed to be a 2-hour surgery. He was in surgery for 5.5 hours.
Wow.
So the surgeon got in, was accountable, and rather than closing him up and saying, "Oh, we need to do another surgery," he just went ahead and did a good job. And he had actually trained with the physician that was at Johns Hopkins and is now at Virginia, I think. Do you remember that doctor's name, Randy?
Falling a blank on his name.
Yeah,
I know
Paul,
exactly who you're talking about.
Snatch right up. But he had trained under him and was in the Chicagoland area, actually in Kankakee, and really quite an amazing story. And the guy was just so relieved. And I went over to his house after the surgery just to check up on him. And he was standing there. We were chatting, and he goes, "Oh, gotta go," and rushed off to the bathroom. And his wife looked up at me and just with a beaming smile goes, "Isn't it great? He can go." Because what had happened was with the distortion that he had, the bone was actually cutting into the nerve that went to his rectum. And so for about 3.5 years, he couldn't have a bowel movement without assistance.
Wow.
Like an enema or something like that, or a suppository, and the nerve was about 85% cut, according to the doctor, but somehow it revived. You took that noise off, and somehow it reactivated, and suddenly his bowel would function normally, which for him was just, that was all worth it right there, just to get that back after 3 back surgeries. So finding a surgeon trained by this guy or trained with this philosophy could actually really save this guy. ultimately, and get him straightened back out. So they just need to be accountable enough and take the time to do a quality job. And they're out there. They're out there.
Yep. So, absolutely.
Great. I've been sending out some chats about the batch webinar coming up. If you haven't signed up for that, definitely get on our website and take a look at the batch.
Is it on our website yet?
Is it?
I know it was in the Neurosomatic news, but
In
I
the
don't
Neurosomatic news, right? Everybody got that, right?
No, I
I
didn't.
didn't either. No.
Nope, didn't get it.
That's not what I want to hear.
What you want to hear at all, is it?
No, I don't know much about the course at all because of that.
All
Lots
right.
of questions.
Okay,
well, we've gotten a pretty good response to it, but not as good as I had hoped. So that might
so
explain
probably a lot
why.
of people aren't getting it.
Yeah,
Can you send it out to us again?
Yeah, look in your junk mail folder.
Yeah, look at your junk mail. If you don't find it there, send us something that says you don't have it, and we will send it out to you.
Yeah.
Thank you. I know it's not there because I just checked my junk mail today.
Okay.
And
Yeah,
when
one
does
out
But
it
if you
last
send me
month.
an email that says you don't have it, that will be my list of people I need to send off to.
Sure.
So if you could do that, that would be great.
Yeah, so that's Randy at neurosomaticeducators.com.
Hey, Randy,
Or Tracy at Neurosomatic.
I have, before we go, I just have two questions for you.
Sure.
One, do we have brochures that we can hand